The problem begins when you think you know it all. You took a course 5 years ago, 6 years ago, 10 years ago, you did fellowship and residency, and you learned everything you need to know. That's a huge problem. You have to recognize that you're always learning, all right? There's a lot of research that's been done in the past couple years. Are you guys familiar with the articles? Are you guys familiar with the new trends? Let's all get on the same page. And I assure you, by the end of the course today, you're going to go away with so many takeaway points. And again, that's why we're requiring annual updates to be part of our directory, because if we refer the patients, we want to make sure that they land in a safe place. And if you don't have enough information or you think you know everything, that's a huge problem. Just as we say, once you see it, you can't unsee it, we also say that once you learn it, you'll see how much there was to learn all along. Once you learn a little bit, you'll see, your eyes will become open. And that's the approach that we want to take for our pediatricians, ENTs, orthodontists, and the other category. The article I want to talk to you guys about is something that just came out. You're going to see this on social media next week, all right? Everyone's going to be posting on it. How could they post this? How could they, all right? All right, this is one of those New York Times article situations, all right? All right, this just came out. So let me tell you what they did. They got 3 fellowship trained pediatric ENTs, all right? And they decided to do this study, all right? And they are sitting there on social media and they're seeing all these posts that don't agree with what they're saying. So what they did is they said, let's do a study proving how much misinformation is on social media. And so what they did is they went to Instagram and they typed in hashtag tongue tie, hashtag lip tie, hashtag buccal tie, all right? And they pulled up, so they said, all right, what are the top, most liked, all right, most shared, like everyone's engaging, the top 100 tongue tie posts, all right? You would think that, hey, everyone's responding to this, there must be some good information on that, right? The top most 100, the top 50 of buccal and lip ties, all right? And they assessed how much was true and how much was not based on what they thought, right? I'm a pediatric ENT, this is what I think, doesn't line up with what I think. So what they found is that 89% of the articles on social media had misinformation. They were lies, okay? They're lying to the public. So let's go through it because it's going to come up and you guys should know about it. And so they wanted to evaluate the quality, accuracy, and readability of social media posts. There were 200 posts total and they analyzed them. There were 3 people who analyzed them. They came out to 71 unique posts and they found that almost all the articles had misinformation and the majority of them had more than 50% misinformation. So it's not just they missed it a little bit, but they were totally wrong, all right? Here is some common misinformation. Tongue ties cause reflux, colic, and mouth breathing. How dare people say such misinformation, all right? Wow. Can you guys believe this? Do these pediatric ENTs really publish that it's misinformation that tongue ties cause reflux, colic, and mouth breathing? What do you guys think? What do you guys think? Can tongue tie cause reflux, colic, mouth breathing? Let's get a unanimous, yeah? It's like what? What garbage is this? It's like a joke. Read it and laugh, okay? Ha 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 ha. What a good one. That's a good one. I didn't see that one coming, okay? That's how you should be reading this. Now someone asked me, what do you think? I said LOL, all right? It's funny. It's not. So here's another topic that I want to talk to you guys about. This relates to mold, all right? And so mold is, fungus. And it turns out that some people are very sensitive to mold, all right? Mold inhalation, if you have, a lot of dampness, if the humidity is high in your home environment, it can actually grow in the bathroom, in the walls. And when there is toxic mold exposure, we get large tonsils and adenoids. And if you don't address the mold, the tonsils and adenoids regrow. Not only does it cause problems with large tonsils and adenoids, but it can cause neural, cognitive, and emotional dysfunction. If your immune system's not right, if you're not sleeping right, it causes inflammation. The inflammation has been shown to increase your cancer risk, infection risk, neurodegeneration, cardiovascular disease. Breathing is the beginning, but breathing is just the beginning. So we also have to be looking at all of these other aspects of health, functional medicine, root cause. That's what we're about. Root cause approach, whether it's integrating primitive reflexes or identifying the presence of mold in our environment or toxic, microplastics, seed oils, diet, nutrition, food coloring. All of these things play such a pivotal and instrumental role. New definitions. The tongue base is the posterior 1/3 of the tongue. Okay. It's all good. We learn. All right. Then we have the tongue body. All right. And the tongue body is part of the anterior 2/3 of the tongue. It's in the middle of the tongue. It plays a role in those RSKG sounds. And, there's the anterior tongue body that's beneath the hard palate and the posterior tongue body that's below the soft palate. And when we're talking about posterior tongue ties, we're talking about the very, very front aspect of the body of the tongue. The tip of the tongue is the very tip of the tongue. What we're really talking about is the blade, and the blade is that part that goes up and down. The body just moves up and down this way. The tip can actually retroflex and anteroflex like that. And this plays a role in TLND sounds and, chewing, swallowing, things like that. So instead of talking about posterior tongue mobility, we don't talk about that anymore. We talk about mid-tongue mobility. If you're writing a report that says posterior tongue mobility, it's really not up to date, which is why we're here at this update course to make sure we're all in the same language. If you put that in your report, you're going to get shut down by the pediatricians and you're not going to know why. All right. Hopefully this gives you a new understanding of posterior tongue tie. If you're going to use the term posterior tongue tie, make sure to put a dash between the tongue tie here. It's not posterior tongue tie. It's the more posterior of the two potential locations for tongue tie. Here's a case, all right, that has a 33 millimeter intermolar width, but the nasion basion is 118.2. And with the 118.2 has a very narrow 1 to 2 millimeter airway. So we're going to look at the CT scan. This is a case that I denied. I rejected her from doing the tongue tie procedure. You can see that it's compensated, all right? And she's maxed out. The max forward head you can do is like 120, 125. This patient does not have a buffer zone, okay? She's maxed out in her compensation. I did a sleep study. The sleep study was not that significant. Nevertheless, I don't feel so great about releasing her tongue tie. Kevin, will you pull up her
Yep,
CT?
perfect. So for the NBC3 angle, you want to come to like the mid-sagittal plane. And so, one of the ways you can know you're there, obviously, is sometimes you can see like the nasopalatine duct. So you want to be around the mid-sagittal plane. And then you're going to take an angle from nasion to basion to the upper anterior point of the third cervical vertebrae. So this patient's NBC3 angle is 122 degrees. So this is a forward head posture, right? Compensation. And then, airway measurements, depending on the software you have, you can either do a two-dimensional measurement. You can take a length of the posterior airway space, right? So you can see it's about
Yes.
3.7.
Great. And then the baseline reference we want is like 1 to 1.5 centimeters. Anything less than 1 centimeter, like 9 millimeters, is 90%, 80%, 70%, 60%,
Correct.
50%. Would you agree with that, Kevin? So 3 is like
Correct.
30% of an
Oh
airway.
yeah, like 11 is considered like
Good.
is normal, right? If your software has it, you can also sometimes do a 3D airway analysis and letting me do it. So kind of pick 2 points,
Yep.
and then now you can get a 3D analysis of the
And
airway.
that is despite the nasion basion of 122, right?
Correct.
So she can only go to 125. So she's maxed out in terms of how forward her posture can go. Now, if her head was back and you have a narrow airway, well, you can put your head forward. It's a dynamic structure. So the teaching point here is we're assessing posterior airway space on the context of what's your head and neck posture. Where are you? Are you tucked or are you out? That's where you want to kind of get it, right, Kevin?
Exactly,
Amazing.
exactly. So this patient in their compensated state has a really narrow posterior airway space. 3D wise, the most important measurement you guys should be looking at is something called the minimum cross-sectional area, basically going slice by slice through the airway, measuring the area at each slice. I kind of tell patients it's like the square footage of a room, but we're measuring in square millimeters. And depending on the study you look at, you don't want to be anywhere below 150 or sometimes even 200 millimeters squared at your most narrow point in the posterior airway space. This patient, despite having an NBC3 angle of 122 degrees, has a minimum cross-sectional area of 68.7 millimeters squared. And you can see on this color-coded graph how narrow that is. They're all the way in the black.
Amazing, amazing. Measure the intermolar for us, Kevin, both at the CE junction and at the bone level, if you don't mind.
For sure. So when I'm doing a transverse maxillary analysis, I do come to the first molar area. So this patient has impacted third molars. These are her second molars, and these are her first molars. So at the first molar, oops, I'll take a skeletal measurement. So I'll measure the width of the maxilla at the first molar, and you can see that I'm going kind of the most concave portion of the maxilla. This is like your skeletal base width. If they had no teeth and the bone atrophied away, this is where they would atrophy to. So I'm measuring a true kind of skeletal basal width, and then you can do the same thing in the mandible at the furcation. So this patient is probably also narrow on the mandible. So ideally, this is more of there's no like hard number that is normal. This is more of a relative measurement. An ideal relationship, right? Your maxillary teeth sit wider than the mandibular teeth by about 2.5 millimeters. So skeletally, if the teeth are not tipped, you should have a 5 millimeter wider maxilla than a mandible.
Beautiful. So
So
this measurement tells you if you can and should do MARPI, okay? If the maxilla, like the maxilla can be the bone of it 5 millimeters more than the mandible. So if you're gonna do a MARPI on this patient, okay, the most you could probably go is go back here. So you probably go to like 60, right? So that gives you about 3 or 4 millimeters of transverse possibility. All right.
correct.
Now measure the CE junction. That's the one that we use that we're saying 32 millimeters. I'm measuring it at the tooth level, mesiolingual.
So I scroll right till I get out of the bone. I'm at the CEJ right around here, right? Maybe right there. And then I'll go from about here to here.
Great. So about 34.3 millimeters. Again, every time you measure this, you'll be off by 1 or 2 millimeters.
Yeah, really.
Okay, you're not going to get a perfect result. If you're looking for a perfect result, you can do like iotero scanning. So your measurements are, within error a couple millimeters. So before I
Yeah.
measured it about 33, he measured it here 33.8. That's pretty good, within 1 millimeter. All right.
Yeah. That's pretty
And
good.
then based on the bone way that he discovered it, if you wanted to do MARPI, you could do about 4 millimeters of MARPI successfully without causing, stability issues. Is that right? Okay.
That's correct. So this will let you know, like, do you have room to upright the mandibular teeth to account for the skeletal expansion that you're going to have? If you need to push someone past that 3 or 4 millimeters that their native bone will allow you, then you're thinking about maybe doing SFOT on the mandible, or potentially even now what we're doing is mandibular distraction. So doing mandibular midline distraction is another way to allow you to get more expansion on the maxilla if it's necessary.
Beautiful, beautiful. And then, so tell us how you determine anterior posterior issues.
So that's great. So most traditional studies are going to be based on SNA and SNB angles. Okay. Um, I'm not a huge fan of it. I added in my notes just because insurance companies like they want to know what patients' SNA and SNB angles. I would tell you there's very little predictability in assessing whether someone is truly like retrognathic or prognathic based on those numbers. Also, there's a whole nother debate we can get into on whether those measurements were done on deformed skulls. So, like if everybody is retrognathic and then we're using that as the baseline, modern humans are retrognathic, it's like determining blood glucose levels that are normal based on a diabetic population that's uncontrolled, right? So these measurements I'm not crazy about, but I still do them, but I'll show you how I do them. You basically go from the middle of the pituitary. So you go from here, sella turcica to nasion, to the A point of the maxilla. So this patient's SNA angle is 83 degrees. That is considered normal, 82 plus or minus 2 degrees. And then SNB to the mandible. So again, sella turcica to nasion to the B point of the mandible. This patient, 75. That should be 80. Now, a really good measurement is something called the ANB. So this is from the A point to nasion to B point. And normally this should be around 1.6 degrees apart. This patient is 6.8 degrees. So that lets you know that the mandible is really protruded in relationship to the maxilla. The
Beautiful,
the
beautiful.
measurement I like to do, I sorry if to interrupt, but for forward growth for the maxilla that I think is really good is something called the Andrews line or the Gall line. So for this, we're actually using the forehead. So there's a lot of studies that actually show that your maxilla, the teeth, should grow up to where your soft tissue glabella is. So on a CT scan, well, this patient's head is forward, right? We said they have an increased NBC3 angle, so I'm actually going to tip their head down just a little bit to account for that. And then I'm going to come to their glabella, soft tissue glabella, so their soft tissue forehead, and I drop a line straight down to the ground. And I want to see that their maxillary teeth have grown up to this line. So this patient actually has grown up to the soft tissue glabella, the Andrews line, and their SNA is normal. So anterior growth on this patient's maxilla is probably pretty good, but their mandible is severely retruded, right? Um, so I hope that makes sense. Does anyone have any questions about how I
Beautiful, beautiful, beautiful. So what are you thinking overall? She's 21, okay? Let's go back to her presentation slide. Okay, so here's her case. She's 21, TMJ, pain, dysfunction, neck and shoulder tension. Does anyone here think that she's a good tongue tie release candidate? You're going to cure her of all her issues with this tongue tie release. Anybody? Anybody? Okay, I don't know. I don't know. In fact, if you do this procedure, you get into genioglossus muscle, you're doing a deep dissection, this patient may end up in the ICU because of swelling and other issues like that. This is a tongue space issue. Tongue space, all right? Hope that was a good example. Now, Dr. Koppelson, what would you offer this patient? MARPI, SFOT, jaw surgery, 21-year-old patient.
so I would
I'll give you this slide back if you want to look
I
at this.
would I would I would take a history on this patient, right? So I would want to know how's your nasal breathing and how motivated are you to have the best airway possible, right? Some patients, if they have really poor nasal breathing, I'm going to push them to do MARPI first, just because you get that mid-face expansion, you get that opening of the nasal cavity three-dimensionally, and it's pretty easy to do on a young woman, right? Just put a MARPI in, and you can have these changes, pretty low risk. Some patients are just going to be like, listen, I want to do things as simple as possible. One surgery. She's so mandibular deficient that I think MARPI is unlikely to give her long-term cure as she ages. So I would be like, at some point, you're probably going to need MMA surgery. And you can widen someone's maxilla during MMA surgery. So the two options I would give this patient, ideally MARPI first, get mid-face expansion, open up the nasal cavity completely three-dimensionally, and then do ortho to get you ready for maxillomandibular advancement surgery. Or if you want to keep things like just, hey doc, just one thing, get it over with, I would say let's do maxillomandibular advancement where I can address her bimaxillary retrusion, but mainly mandibular retrusion, and I would do a segmental effort widening of
Beautiful,
the maxilla.
beautiful, beautiful. This is why I love having you in my clinic, okay? Break it down. It makes sense, easy to digest. And the second factor is seeing the patients where they're at, okay? Yes, you look at it, you're like, all right, three-piece LaForte, MMA, GTA, but this patient came for tongue tie, all right? And here's to come for tongue tie, you're not looking for jaw surgery. They're trying to avoid that. So you got to kind of see where they're at, start with the maxilla, but also set a framework for this is just the beginning. It's not going to be the end, all right? How good was this case? Do you guys want to see four more? Should we keep going? The only true wisdom is in knowing you know nothing. A quote by Socrates. Wow. Okay? And it's with this humility that we're going to start our update course with the understanding that, there's a cognitive bias known as the Dunning-Kruger effect, where You learn a little bit. You see like a post on social media where someone's tongue tie gets better or something like that. You decide you can do it. You're like, oh, that's easy. I could do that. All right. That's the peak of ignorance. All right. You learn a little bit. You become cultured. You become humbled. You get a complication. You're like, oh man. All right. And then you start to learn more and more and more and more over time, yet never reaching the point where you're so overconfident that you decide that you know it all. I've already learned this. I know everything. There's nothing left to learn, which is never going to be the case. And so we're going to use research as our compass to guide us, to give you confidence, to give you a solid foundation with the motto that innovation leads and research follows.